Okay, well, welcome everybody to this Dean's Corner Quick Takes session today. The Dean's office told me that I have 20 minutes to tell you everything that you need to know about healthcare spending in the United States. So we're going to have to move really quickly. Realistically, though, there are so many things to talk about in healthcare spending. We could spend hours on any of these topics. So these are the 5 questions that I want to touch on. Ultimately, what I'd really like to do is just give you some background information and a slightly different perspective, and hopefully you can be better consumers of information and evaluators of the discussion that takes place regarding healthcare spending in the United States. I'm going to move fairly quickly, I think, through the first few questions on this list because they're relatively straightforward. And as we get to the end of this list, questions 4 and 5, that's a little more complicated. Okay, so what is the trajectory of U.S. health spending? Well, we spend a lot of money on healthcare, and we're going to spend a bit more money on healthcare as we go forward. So we were at about 4.1 billion or 4.1 trillion dollars spent on healthcare in the United States in 2020, and that's expected to grow to about 6.8 trillion by 2030. And just for kind of relative terms, in 2020, 2021, we're at about 18%, a little over 18% of GDP spent on healthcare. And by 2030, that's expected to be about 19%. So a bit bigger share of the economy. One thing to keep in mind, though, is these are projections. So if we roll the clock back 10 years or a little bit more, we were expected to be at 20% of GDP spent on healthcare already, even a few years ago. So things change. But the one thing that we can be fairly confident about is we are going to spend a little bit more. Note the categories here. The largest category of healthcare spending is on hospital care. The second largest category is spending on physician services, okay? And prescription drugs is the third largest identifiable category, not other health spending or other personal health care. Okay, so not surprisingly, these categories, the larger categories, are the drivers of the increase in healthcare spending over the past several years and going forward. So although we hear in the popular press all the time about the increasing costs of drugs and increasing spending on drugs, that is not where the cost growth is. Over this period in the chart, 2010 to 2018, spending on hospital care was the largest increase. 35% of the total increase in health spending was on hospital care, and 20% of the total was on physicians. Drugs accounted for only about 8% of the cost growth. I'm just going to flip backwards here for a second. And you can see that, hospital care is about 30% of health spending in 2020, and physicians were about 20%. Note, as we go from 2020 in this pie chart to the 2030 pie chart, hospital care is expected to grow from about 31% overall to almost 33% overall. So hospital care is projected to grow faster and constitute a large share of the increase in healthcare spending over the next 10 years or so. Okay, so within those categories, what's driving the increasing spending on hospital care, the increasing spending on physicians, those two big categories? Well, the American Hospital Association did a review in 2021, and they concluded that over the previous several years, that increasing use of care and increasing intensity of care, meaning using more high-tech, high-cost care, and shifting to higher tech types of care, accounted for the majority of the increase in healthcare costs. This is not surprising that this is the same finding that comes up again and again. The Congressional Budget Office did a meta-analysis back around 2000 or so, and they found in the 50-year period from 1940 to 1990, the same two factors, increasing use and use of higher technology, accounted for the majority of the cost growth over that period. So the bottom line is Americans like access to healthcare, and we want access to the most advanced healthcare that's available and proven to be effective. And that's what's really been driving our cost growth. So what are providers facing right now? Well, I mean, over the past couple of years, a significant focus and concern has been workforce challenges in hospitals, largely due to shocks from the COVID pandemic. So we have not just the working conditions that were existing in hospitals causing folks to leave the profession, but then also the vaccine mandates. Both of those together caused shortages in workforce in hospitals. And not only in hospitals, but in nursing homes. Those two factors together have led to patients building up in the hospitals. Patients that should be discharged to nursing homes are not able to, because there are no beds in the nursing homes because units have been shut down. So you have patients backing up in the hospitals, shortage of nurses and other clinical staff to take care of those. And hospitals have been shifting to using travel nurses and other methods of staff, having the staff to treat the patients that in the past would be temporary solutions, but they're kind of sticky right now. And when you have these huge costs for travel nursing, it's difficult to find money in the budget to increase pay for staff nurses so that you can try to transition back. And at the same time, thinking of this from the nurses' perspective, and it's difficult to attract staff nurses when travel nurses are making maybe 50% more or even higher premiums to be travel nurses. So that this is a significant challenge facing hospitals right now. Prior to the pandemic, and still in the background, that this shift that I'm about to talk about is still taking place, was the shift from a fee-for-service model of care to a value-based model of care. So fee-for-service, healthcare providers, hospitals, physicians get paid for providing an instance of care. Value-based is trying to shift that to paying for the quality of care, or paying for good care being delivered rather than just quantity. And as part of the Affordable Care Act, Medicare tried to push this change, or catalyze this change to value-based care with a number of initiatives. Medicare, accountable care organizations, and bundled payment being the two biggest issues or initiatives in value-based spending within Medicare. Unfortunately, they don't appear to be clear winners yet. So Medicare ACOs don't appear to reduce spending very much, maybe less than 1%. And also switching to this accountable care model, which really involves trying to use information technology and other tools to make sure that only the correct care is being provided, that's a significant infrastructure cost for systems. And by some estimates, the infrastructure costs for hospitals eat up a large portion, or even perhaps all, of the shared savings that they get from Medicare in this program. Bundled payments, the other initiative, they've been very successful in reducing spending on major joint replacement, but they haven't really been very successful in reducing spending in other categories where bundled payments have been tried. But Medicare is still committed to this shift to value-based payment, while most of hospital payments still are fee-for-service. And so providers and healthcare institutions are trying to figure out how to be successful in both models simultaneously. They need to be successful still in fee-for-service because that's where most of the market is. But if Medicare completes a shift to value-based payment, Medicare is the largest payer, and providers are going to have to figure out how to be successful in that modality. And so that's something that continues to be a concern, even though over the last couple of years, workforce shortage issues and other pandemic-related issues have been more front and center. Okay, so is healthcare spending too high? Well, what do we mean by too high? We have to parse this a little bit. What do we mean by too high? And who gets to choose or decide whether or not our spending is too high? Those are kind of foundational questions that really I don't think that we really have time to get into. But we can think a little bit about how high is our spending? Why do we spend so much? And what do we get out of that? Okay. So how much do we spend? We spend a lot. We spend a lot on healthcare, that's for sure. And we spend a lot more per capita in this country than other developed countries do. And why is that? Well, in part, it's because we have a lot of money to spend. Compared to other large developed countries, our per capita GDP is much higher. To the point where even though we spend a lot of money on healthcare, if you take all of that money and take it out of our GDP and do the same for other large developed countries, we still have more wealth left over. So we have a lot of money to spend, and we choose to spend a lot of it on healthcare. Okay. A second issue is that we pay a high price for the healthcare that we get. You'll often read this in the popular press. The prices are a problem. Okay, well, why is that? Well, part of it is because everybody in the United States makes a lot of money. So nurses and physicians in the United States make a lot of money compared to similar folks in other developed countries. Okay, so this is just one good example. In the National Health Service in the UK, the salary range for a general practitioner, so like your doctor that you would go to see, is in the range of $83,000 to $125,000. Okay, nurses in New York average $93,000 per year. Nurses in California average $124,000 per year. So physicians in these other developed countries are making essentially nurse pay scale. Okay, and think about what we're seeing lately. How would we cut pay to healthcare professionals when pay is going up in other places? We see help wanted signs on McDonald's offering $21 an hour. You know, annualized, that's $42,000 per year. And now we have people that are going to 4 years of nursing school and taking on a very demanding job. It's going to be difficult to pay them less than we're paying right now. Even if we could figure out a way to pay less, what is it that we should expect to get? Okay, if we push down wages in healthcare, we would expect fewer people to choose careers in healthcare. And so philosophically, you can think about young, bright people. What do we want them to do? You know, someone that is going to go to medical school, give up 4 years of their life to medical school, give up a minimum of 3 more years to residency. This is a significant opportunity cost, 7 to maybe 10 years of either earning no money or little money. They want to get a return on that. And if we push that return down, careers in other sectors, law school, career on Wall Street, those are going to look a lot more attractive to people. So do we want our best and brightest pursuing careers in healthcare, helping patients, looking for the next cure for a disease, or do we want them choosing other careers? So we have to think about the outcomes. Yes, we'd like to spend less, but what happens if we choose to do so? Okay, so what about what we get for that money? Okay, so do US health outcomes justify higher levels of spending? So here, I'm going to give you a little bit different perspective, perhaps, than you often see other places. This chart that you see right now, this is taken from a prominent health economics textbook. You often see charts like this, very similar, where the United States, it appears to be a significant outlier. And typically when you see a chart like this, you see something along the lines, commentary along the lines of, we spend a lot of money on healthcare and we have worse outcomes than other countries. Okay, well, what I want to do is talk about how these kinds of charts can be very misleading and how they don't factor in things that we know that are true. Okay, and so they can give a very distorted perspective. So this chart, for example, has a few very significant shortcomings. The truncated axis is a significant issue. This assumes, with a linear regression, that we're going to have constant returns to additional spending. This is based on OECD data, but it excludes some OECD countries for reasons that aren't clear. Okay, so I just want to show you, when we make some adjustments, what this looks like and provide perhaps a different perspective. Okay, so this is my chart now using OECD data, looking at male life expectancy at birth, just like the previous slide. And let me just flip back and forth so you can see that it looks substantially the same. Okay. All right, so this is my chart so that I can make adjustments to it. Okay, so the first one is, I mentioned the truncated axis. What does a truncated axis do? It spreads the data points vertically. Okay, so if we just stop truncating that axis, this is what it looks like. Okay, just that one visual change, it becomes apparent that the real reason the United States is an outlier is because we spend a lot of money. It's not really that we have lower life expectancy significantly than we would expect. That's a little bit true, but largely it's just because we spend so much on healthcare. Okay, this chart still assumes constant returns to spending. And why should we expect that? I presume most of you, that since you're on this, and this is for alumni, you've been through a business program. Diminishing marginal returns is a feature that we see almost everywhere. So why should we expect linear returns to healthcare spending? Okay, so we know that there aren't linear returns to healthcare spending. So let me just take a moment. I'm not trying to pull a fast one. This is now life expectancy at birth and GDP per capita. And these are all of the countries in the world for which any data can be generated. This is GDP per capita because we can't really get healthcare spending for the full set of nations in the world. Okay, so what we do know, however, is that GDP per capita is an extremely strong predictor of healthcare spending per capita. Economist Uwe Reinhardt from Princeton, he estimated several years ago that GDP per capita accounts for about 90% of the variation in healthcare spending. So it's a good proxy. And what do we see when we look at this chart? This is very clearly not linear. Okay, we can see at the low end of GDP per capita, as nations get richer, they very quickly increase life expectancy. What is this? This is spending on things like clean drinking water, vaccine for fatal diseases, very good nutrition for expectant mothers and babies. These are things that have huge impacts on life expectancy. And then as countries get more wealthy, they spend more money on healthcare, but it doesn't translate into as much growth in life expectancy. Okay, and so that's exactly what we would expect. Part of the reason for this is life expectancy is one measure of outcomes from healthcare. Okay, why do we talk about it? Because it's a very good measure and a consistent measure. Okay, it's something that we can quantify well, and certainly is important, but it leaves out other factors. It leaves out pain. It leaves out how long does it take you to access healthcare. So life expectancy is incomplete. And so what you see is healthcare spending shifting to other components of quality of care rather than just producing increases in life expectancy. Okay, so this chart is taking a look at, well, what if we do two things? And that is, number one, stop assuming linear returns. And number two, adjust the data for social factors. And specifically, the United States has much higher rates of violent death than other developed countries that you see in these charts, typically OECD countries. And what do we mean by violent death? That is primarily motor vehicle accidents and homicide. Okay, suicide a bit is in there as well, but other countries, some other developed countries have similar suicide rates. So the difference really is motor vehicle accidents and homicide in the United States. And so the argument here is just geographically and structurally, the United States is different. We are a continent-spanning country. We are much less dense. Our population is spread out. People drive a lot more. And as people drive more, they're more likely to be in a motor vehicle accident and more likely to be killed. And is that an indictment of our healthcare system? I would argue no. I think most people would argue no, that we don't need to completely reform and change our healthcare system to try to solve the problem of people drive a lot in the United States. And that's unlikely to work. Okay, and then we have social issues in this country that lead to relatively high homicide rate. So if we normalize for that, so this is based on research done by Osfelt and Schneider, they took a look at the violent death rate in the OECD countries and normalized it and said, what if you had the same violent death rate in all of the countries? What would life expectancy look like? And surprisingly, the United States ends up at the top of that list when you do that adjustment. And so if we adjust for that violent death rate, we adjust for the fact that we shouldn't expect constant returns to healthcare spending, you end up with a chart that looks like this, where the United States is almost exactly on the trend line, and we have the life expectancy that we would expect based on our healthcare spending. Okay, another way to look at this, and I didn't want to just give you a barrage of charts today, is to look at what happens when an individual is diagnosed. Okay, so when we look at life expectancy, we are looking at the whole population rather than what value do we get from the money that we spend on episodes of care. And so one measure to look at is cancer survival rates. There's a study called the Concord study that has been run through a couple of iterations. And so if you look at patients who have been diagnosed with cancer, the United States has the highest or second highest survival rate in the four largest categories of cancer: lung, breast, prostate, and colon cancer account for 83% of all cancer cases in the United States, and the US ranks first or second. Okay. Also, we can take a look at other things. As I said before, life expectancy is one important measure, but it's incomplete. Okay. We end up spending a lot of money on other things. Okay. I want my mother to get the hip replacement when she's in pain and having a lot of difficulty walking. And I don't want her to wait 6 months, 12 months, 18 months to get that hip replacement. Okay, so we spend money on getting relatively immediate access to care that the hip replacement is not going to significantly extend life expectancy. So kind of coming back to this, we spend a lot of money on care because we have a lot of money to spend, number one, and we choose to spend it on healthcare. Number two, we end up, if we want healthcare and we want high quality healthcare in the United States, we're going to have to spend more than other countries because healthcare is a relatively labor intensive industry, and everybody in the United States earns higher wages than their counterparts in other countries. Okay, and so if we can, in the long run, we can hope for some technology innovations, whether that is artificial intelligence, helping to diagnose people and treat them earlier, or a cure for cancer, or other technology that leads to reduced use of care. That would be fantastic. Until we get to that, reducing healthcare spending in the United States is going to be some combination of restricting access to care that's available or paying people less, with the result of, ambitious, very smart people choosing careers in different fields. Okay. All right, so that's what I had prepared today. So let me take a look at these questions. Okay, so one question is, what role do insurance companies play in escalating demands and costs on physicians and their staffs, leading to departures from healthcare professions? I think certainly there is a challenge, and healthcare workers feel that they spend a lot of time on that. I think the more significant role of insurance and how it's different in the United States than other countries, and why other countries can spend less on healthcare is most other developed countries have single payer, and single payer is a monopsonist. Okay, so you probably all in your business school program learned about monopolists. I'm not sure if you discussed monopsonists, but when you have one buyer, that buyer spends less than you would if you had multiple buyers. And they do it in a similar fashion to how monopolists do it. So you get less care at a lower price point in monopsony. And so that's why you see queuing, you see other restrictions on access. And so we don't have that single payer model. We have multiple payers. Those payers, being somewhat fractured, are not able to negotiate lower prices for care. And there's competition between them. Americans want access to high quality care and relatively immediate care. And so, and also remember that the majority of non-elderly Americans get their care through employers. So as employers are trying to attract employees, one of the ways they do that is with their healthcare benefits. And so there's competition in that area. And what we actually see is healthcare spending through private insurers has been growing faster than healthcare spending through Medicare and Medicaid. Okay, why? Because working people want access to healthcare, and so they're demanding it through their employers, and that those costs are growing. Okay. let's see. There's a relatively long question at the top. I'm having a hard time reading. Doesn't managed healthcare have a big impact on spending? Not compared to the other categories that I was talking about. Net cost of health insurance is the category that you would want to look at. And in terms of the share of costs and cost growth, it's a fraction of what we spend on hospitals and physicians. Okay. There's a question about infant mortality. We read so much about the US having significantly higher infant mortality despite our higher level of healthcare spending. You know, that's interesting. I didn't put this in here because I only have 20 minutes. I can do a very similar presentation with infant mortality that I did with that life expectancy chart. A lot of what you see is misleading. The large majority of the disparity in infant mortality between the United States and other countries has to do with gestational age. So we have a lot more babies that are born before 40 weeks than other developed countries. That's in part due to teen pregnancy. Teens are more likely to deliver early. It's part due to demographics. People of African descent are more likely to deliver babies prematurely. And that's true of people of African descent living in Africa, living in Europe, or living in the United States. So we have a much different demographic mix than those other countries. And when you adjust for preterm births, then you really see very little difference in the US infant mortality rate than other countries. And so the argument there is we need to figure out how we can provide what we can to expectant mothers ahead of time. And that's where the money should be spent. When you look at once a baby is born, and the care that they receive in NICUs, for example, that's another problem with infant mortality stats is the United States counts any baby that is born alive as a birth. Other countries restrict it. If a baby is below a certain birth weight, they don't count that baby as a live birth. And so the stats are skewed. But there really is no question that, much like the cancer example that I gave, that once someone is diagnosed, once there is a health issue, such as a preterm baby, the care and the technology that's brought to bear in the United States is absolutely excellent. Okay. Quick question. When you say multiple payers, are you referring to multiple people in a household? No, I'm talking about the difference between single payer. What if the US federal government was the only, quote, insurance? What if everybody had Medicare? That's single payer. Versus in this country, we have elderly folks on Medicare. We have people that can't afford healthcare on Medicaid. And we have most of the rest of the people getting insurance through their employers. And so you have multiple insurance companies, United Health, Cigna, et cetera. Okay. So understanding prevention makes logical sense. Why lump motor vehicle death together with firearm death data? Prevention of death in these situations is different. So sure, I mean, we could say that, you know, structurally motor vehicle accidents and firearm death are different, but I guess the point we're trying to make is when we talk about healthcare in the United States, usually we're talking about we need to change how we're going to pay and how we're going to deliver care when somebody needs it. Neither of those things are going to prevent people from shooting each other. Okay. Neither of those things are going to prevent people from driving, 30 miles one way to get to their job. And so that's why the argument is to take them out. Certainly, you can make an argument that we should be spending money on trying to prevent people from shooting each other, but that doesn't mean that we need everybody to be on Medicare in order to do that. So that was the point that I was trying to make. Okay. I'll try to get back up here to the long question and scan it quickly. Okay, so this basically I'm not going to read this question in full, but there's a question essentially. There's a trend in hospital systems in buying up medical practices and then being able to charge higher prices for the same care. Yes, that is an issue. It is not the primary driver of the increase in spending, because we've been seeing the increase in healthcare spending through hospitals for decades, and that this is a relatively recent trend. But you do bring up a point, and this is a risk associated with accountable care organizations and value-based health. So accountable care organizations briefly shift some risk from the insurance company or from Medicare onto providers. We did this back with capitated payment in the 90s, and now we're trying it again with a wrinkle, a slight difference, but it does push risk onto providers. And how do you handle risk? You handle risk by getting big. You average out the risk across of individuals across the big pool, and it's more efficient. And so the federal government has been allowing hospitals to merge and allowing hospitals to buy up practices to a degree that would not have been allowed before the push towards accountable care organizations. So this is one of the downsides of this push to value-based health, is accountable care organizations don't seem to save much money, and they're catalyzing this increase in scale on the provider side of healthcare, which allows them to raise prices. And certainly that is something that is going on. Okay. We need to move from a focus on cure to a focus on prevention. Your example of a delay in joint replacement is not having an impact on longevity, misses the point on quality of life through lifestyle modification. Moving to this model will decrease spending overall. Sure, if we can figure out how to reduce obesity rates in the United States such that people don't wear out their knees and hips, we won't have to spend money on joint replacement. Changing behavior is very difficult. So if we can figure out a way for people to smoke less, drink less, eat less, that would be fantastic. It's not clear to me on how that's going to happen, and what specific reforms. Is the argument that we are going to stop spending money on joint replacement to spend money on something else that is going to lead to changes in behavior? If so, what proven methods of behavior change do we think we can deploy at scale across 350 or 360 million people that will lead to a change? And so I think that's the other thing that I like to impart through these when we say we're spending too much on X. Okay, well, if we spend less on X, what are we going to spend that money on? Do we have something that looks like it will work? And I think one of the key things is there are no easy answers. If there was an obvious way to reduce obesity in the United States, I don't think you'd have much argument in spending money on it. The trick is finding that way that we are confident is going to work. Okay. There's a question, have you seen any data that compares U.S. out-of-pocket expenses compared to other countries and how that relates to outcomes? Nothing that I would be able to quote for you right now. I'd want to be very careful about that. I think one interesting thing, though, is although we feel the pain on out-of-pocket costs, if you look historically, out-of-pocket share of spending in the United States is much lower than it was 40, 50 years ago. So out-of-pocket spending as a share of spending in the United States has actually been decreasing for decades. Now, why do we feel that pain? Well, because we're spending a lot more. So that the percentage is going down, but individuals are spending quite a bit. There's a question, what's your opinion on the cost saving that could be led by better communication relationship between payer and healthcare professions? Any relevant cost saving model we could reference to? Well, in some sense, accountable care organizations are trying to do that, right? Accountable care organizations say, based on this individual's past spending and their diagnoses, we expect that it should take, $10,000 or $12,000 to care for them for the year. So you go ahead, provider, accountable care organization, and provide care, and you make the decisions on what care will be provided and what won't to try to hold down those costs. And so that eliminates the communication problem and makes it so that all of those concerns are internalized, and that hasn't worked extremely well. So it looks like everybody's leaving. Thank you for joining. I appreciate it.